So we're just going to get right into it, ventilator management. What we're going to be going over in this course is we'll talk about the basic modes what we have, different modes of different between pressure and volume control. Really more of the focus that I really want to focus on with all this is that I feel overall we don't have issues knowing what the difference between AC and SIMV are, why we're using targeted volume versus targeted pressure. It's more in the aspect of our non-invasive modes that we seem to need the most troubleshooting with. So we will have a number of scenarios going over BiPAP. Everyone should have gotten an initial sheet for, this is basically BiPAP settings for dummies on how to initially set it up, on where if you were to take someone out of off well, where they're at, what we should be as far as adjusting to making sure that our patient is doing the best they can. We'll also talk about initiating BiPAP in the field and what we have available to us to make sure that we have the most appropriate settings for these individuals. So, like I said, we're going to spend most of that time going over those kind of scenarios, not so much over here's what AC mode is, here's what SIMV is, but we will touch on just a little bit. Again, overview, the type of ventilator that we have, different modes that we've got, your initial setup, some of the troubleshooting that you're going to have during your vent transfers or initiating event. Basically, we'll talk about the dope mnemonic and other aspects clinically that you need to look at on why you might be running into the problems that you have with your patients. And then we'll go over some of the scenarios afterwards. So straight up out of the manual for the Zoll Vent is that it is used to management respiratory distress arrest patients anywhere from an infant to adult greater than 5 kilograms all the way up to the adult level, doing positive pressure ventilation. So the Z-Vent ventilator is intended to be used for skilled care providers with knowledge of mechanical ventilations, i.e. you guys. You guys are going to be the ones who be setting this up. You guys will be correlating this with Bothwell if you're taking any vent transfers, correcting the issues that they have because they just love to throw it in the rescue mode, which is at 500 of volume, 12 of a respiratory rate, FiO2 of 100, and then just wing it from there. Hopefully someone figures it out because they won't. Different modes that we have, again, assist control, synchronized intermittent mandatory ventilation. You have CPAP and you have BiPAP. BiPAP is also known as bi-level, and that's what you see as a mode of selection on the Zoll Z series. For assist control, it works by setting a fixed tidal volume or peak inspiratory pressure for the ventilator at set interval times for the patient initiates a breath. AC mode is going to deliver what you set at increments of what you set no matter what. So if you have a rate of 12 with a tidal volume of 500, every 6 seconds, every 5 seconds, you're going to get a breath for 500. If the patient initiates a breath as if they have spontaneous breathing, regardless of how well they're doing, they're going to get 500 on top of that. It's kind of nice in the aspect that if they have someone who is in respiratory failure or who has completely lost respiratory drive, that you're going to be able to give the diaphragm a chance to rest while it breathes for the patient, which is pretty nice because when we have our paralytics that we use, especially if we end up initiating our intubation with a long-term paralytic, AC mode is going to be able to give them that constant pressure, that constant volume, regardless of what's going on with them. Disadvantages, if they're not properly sedated or properly paralyzed, or they have a higher respiratory drive than you're anticipating, you're going to run into issues of overventilating, developing hyperinflation, barotrauma in that aspect. That patient's going to get tired very quickly. They will be bucking that tube. They are going to have auto-PEEP, auto-stack, and causing further problems that we are trying to avoid. Synchronized intermittent mandatory ventilation. Biggest thing about this one is that it will give your set volume or pressure in intervals like AC mode, but this allows the patient to breathe at its own spontaneous rate without any issues. The biggest thing about it, again, if you have a set volume of 500 for a respiratory rate of 12, so 1 every 5 seconds, it will give that first breath that first time. If it does not recognize a breath within 5 seconds, it's going to give its next breath for that 500. If in between that 5 seconds, the patient does breathe on their own, it's gonna allow the patient to breathe on their own, and then it's gonna reset that counter based upon that breath. So that's pretty nice in the aspect that if they already have a pretty good respiratory drive, or they're not as significantly sedated, it allows the patient to continue having that spontaneous breathing, the diaphragm's working. These individuals probably aren't gonna be on the vent for very long. That's kind of a nice mode to have it on. Disadvantages, if they are not properly sedated, or they have an increased respiratory rate that you're not accounting for, you're gonna run into those same issues again with barotrauma, increased pressure, increased volumes. We're gonna have problems with auto stacking, auto P, and further lung damage that we're trying to avoid. CPAP is constant positive airway pressure. Which patients is going to benefit the most out of our CPAP? What's that? CHF? Yeah, people with congestive heart failure. Golden standard right now for treatment of them is getting them on CPAP. This provides one constant pressure of positive end expiratory pressure, or PEEP, that opens up the alveoli, recruits as much as that we can so we can have better oxygenation, better offloading of our CO2, and hopefully make them more hemodynamically stable than what they currently are at. It's pretty quick setup. I mean, we have got the rescue CPAPs that we have. You basically slap that mask on and set your PEEP. Same thing with the vent, it's not very much different. You have it set for a CPAP mode, you set your PEEP, and you go from there. Disadvantages, they've got to be awake, they've got to be coherent, they've got to be able to follow commands to be able to use CPAP. Problem is that if you have an apneic patient or unresponsive patient you're putting CPAP on, it is a constant pressure being pushed through. They have no chance to work against it or offload it. You're just overinflating the lungs. Bilevel. Main difference between CPAP and BiPAP is that we have two pressure settings that we're giving our patient. The initial inspiratory pressure, or IPAP, for also known as our peak inspiratory pressure, and a lower one, which is EPAP, or that positive end expiratory pressure, our PEEP. Does the same support as CPAP. The only thing that's really great about it is because of those two different levels of pressure, the patient can breathe a little bit easier against BiPAP than they can with CPAP. That initial breath is going to be a higher setting of pressure to help drive that volume in. That lower pressure is going to keep that alveoli open so that we are always recruiting as much as we can so that it can do better. One of the disadvantages, and the thing that we see the most problems with, its initial setup can be difficult and requires a greater knowledge of skill. When we talk about our least invasive to our most invasive airways, we go from simple nasal cannulas, non-rebreathers. If we had the ability for high flow nasal cannulas, that would be great, but that would fall in right around where CPAP is. BiPAP is where we're going to be going next, and from there we're going to be doing intubations if they need. So what we're going to see as far as on our ventilator as the different waveforms between AC and SIMV, we're not going to see too much of difference with our CPAP and BiPAP because that's all patient dependent. We don't have a set on what that's going to be. There's no constant with that, so it's always going to be changing. But with assist control, as we look at here, we have flow, pressure, and volume, both sides. As we see with our flow rate or our rise time with our assist control, pretty squared off, it's always consistently going to be the same. As you see over in SIMV, that middle breath given is a spontaneous breath. Doesn't match what we see with the rest of our ventilator, but this is a patient breathing on their own without the vent giving additional support. If we saw that on assist control, we would see higher stacking of our volume, the flow would be a little bit higher, and the pressure would be higher as well. So for CPAP, biggest thing that we're going to go with this, again, we're talking about our CHF patients or people who have type 1 respiratory distress. So these are going to be people who have lung injury. They're going to have aspects of the problems more with ventilation than oxygenation. Excuse me, more of oxygenation than ventilation. These individuals are going to be the ones that have like CHF, pulmonary edema, and another couple other ones which we'll go over here in a little bit. Generally where we start at is at PEEP of 5. Physiologically, right now, where is everyone sitting at for a PEEP that's normal? It's about 2 to 3. That is what you normally are at, is 2 to 3. So CPAP, basically initial starting point is 5. We can go all the way up to 30 on some ventilators. For us, protocol says 15. Anything higher than that, we need to contact medical control or consult with the physician on that transfer if we're taking them out of bottle. Bigger things is this: who's ones are gonna be the ones that are gonna need higher PEEP?
COPD.
Yeah, but that's more going to be inspiratory time. It's going to need a little bit more for them. They're going to be more of a type 2 respiratory drive, or respiratory distress. Then we'll go over that. Your ARDS patients are going to need a significantly higher PEEP than someone who has like CHF. Some of the problems that you can run into when you have really high PEEP is that, try to remember the idea that PEEP is deep. So the higher our PEEP, the greater interthoracic pressure we have. So you've got pressure pushing against the lungs and against the chest wall cavity that are working against each other. If you have too high of PEEP, your heart rate will be increased, your blood pressure is going to start dropping because the heart just has nowhere to squeeze because of the pressure around it to allow it to actually do its job. So always be concerned about that when you start hitting those higher levels, which is like 15 or higher. The BiPAP, again, delivers 2 different pressures: the inspiratory positive airway pressure, IPAP, and the lower expiratory positive airway pressure, EPAP. On our vent, you will see IPAP and you will see pressure support and PEEP. Pressure support is always going to be IPAP. PEEP is always going to be our EPAP. Those are terms that are actually trademarked by Zoll, which is infuriating because when you go up to Bothwell, they are not using a Zoll ventilator, they're using Philips. So just knowing that interchange of terminology will help eliminate some confusion you may run into as far as asking what your settings are, or when you're looking at that vent to copy those settings, or to at least start somewhere, you at least have an idea of what we're looking for. The difference between those pressures is going to be your pressure support. So that's something we always need to keep in mind. Pressure support is simply just BiPAP, and the greater difference between our IPAP and EPAP, we're going to have greater volumes. That's something to consider and recognize when we set up BiPAP for our patients, because we are always trying to reach a target volume based upon ideal body weight. Sometimes that's not possible, and we just need to have some sort of guideline, or at least a ballpark range of which we are trying to achieve when we set this up. Some other things that we'll talk about when we actually do a little hands-on scenarios with the vent is that we will talk about leak control and the aspect of cycle percentage off time. Basically what that is referring to is that at what point does the ventilator stop giving pressure for that initial volume and allow the patient to exhale. That is something that can make or break your patient on BiPAP, and the fact of how comfortable it's going to be for them when they are initially breathing. We'll also talk about rise time, and I'll show you guys how to go through the ventilator to adjust those if needed for your patients. Again, so like I said, those types of respiratory failures that we talked about when we talk about CPAP, BiPAP, those type 1s are the hypoxemia or the injured lung. They have damaged tissue that prevents adequate oxygenation. Prime example, CHF, ARDS, pneumonia, some sort of lung hemorrhaging or pulmonary contusion, or atelectasis. Atelectasis is something that can happen very easily with the vent if you're not paying attention, predominantly if you have larger volumes than what the patient can handle for a pretty long time. Difference what you will see as atelectasis as compared to a collapsed lung is that atelectasis generally has to deal with just a specific one lobe of an area on one side of the lungs. Predominantly, it will be the middle lobe on the right side is where we normally will see this happen first. hypercapnia or obstruction type 2 respiratory distress. These are going to be people with a decreased central nervous system. So either it's a lesion, an overdose, generally if it's like some sort of narcotic, we're going to see anything that's going to decrease that respiratory drive. Anesthesia, which granted it makes sense considering the fact that it's selectively taking away their airway. So something also we consider about is when we do our RSI, DSI innovations, knowing that we are technically putting them in an obstructive type 2 respiratory failure, just considering that when you set up your event. Neuromuscular diseases like Guillain-Barré, anything that's going to cause the drive to breathe to decrease. Increased work of breath are asthma and COPDs, pulmonary fibrosis. Scoliosis is a curvature of this upper spine. Basically, you're going to see this in your very geriatric population where they're just kind of punched over, where they don't have the aspect of having the full volume that they could initiate upon the breath. Pulmonary fibrosis, one of the biggest problems that we're going to have with that is actually lung compliance. They lose the elasticity to actually expand, so you're going to have higher peak pressures with that, and it's just things that you need to be considering about when we set up our event. Okay. One of the biggest things when it comes to our initial setup is that we are always going to talk about calculating our ideal body weight. Every medic on B shift has received a vent card. Do we all still have it? You guys should have it in your pocket at all times. Flo's got it, Donnie's got it, I've got it, Paula's got it. The rest of you guys, shame on you. That card, if you look through it, it's going to give you the down and dirty on the best ways to initiate your vent ballpark way of at least setting it up. It will give you your ideal body weight for both male and female from 5 feet, like all the way up to 6.5, if I remember correctly. Why is ideal body weight so much more important when it comes to calculating tidal volume as compared to doing off of actual body weight?
Well, it's the same thing as medication. If you have somebody that's 600 pounds, you're going to overinflate the lungs, you over-medicate them.
Yeah, depending on which medication, because some medications are water-based, some are fat-based, but yes, the idea is that a 600-pound individual that is 5'4" and a 150-pound individual is 5'4", body mass is different, but your lung size is the same. So they receive the same amount of volume regardless of how large they are. Only issue is that someone who's 5'4" and 600 pounds is that they're going to have that extra pressure of that extra body weight on them. They may need a little bit higher tidal volume to overcompensate that, or we might have to have an increased respiratory rate. If you want to know the calculation on both male and female for ideal body weight, the biggest way that we do that is that for males, baseline start is at 5 feet, the ideal body weight is 50 kilograms. From there, figure out how tall they are in inches over 5 feet, times it by 2.3, and add that to your initial 50. Females, a little bit smaller, 45.5, same aspect, 2.3 kilograms times the number of inches over 5 feet, add it to it. If they're below 5 feet, just subtract. This only works up until about 4 feet. If you have anything less than that, we're talking about pediatrics, there is a whole nother setting, a whole nother calculation that you can use for them individuals, but it's not too far off of what the ideal body weight is for this, for our pediatric patients. Okay. Troubleshooting as we go through a couple of things. Again, as always, your dope mnemonic is the thing that you are going to always start with. So we're talking about displacement or dislodgement of the tube. We're going to talk about obstruction of that tube, pneumothorax, or equipment failure. Always start from your patient and move your way towards your vent. If you're having problems, you're running into issues where your alarms are going off, see what those alarms are telling you and start from there. Start with where it's connected to the patient. See if we have any displacement or dislodgement. See if it was even secured properly before you even left, or has it moved during your transfer at all. Are we having the aspect of like low airway pressure alarms going off? Are we losing air somewhere? Is the cuff not inflated? is there are a leak somewhere as far as in the actual tube itself. We have seen a number of alarms go off where it talks about low O2 pressure, where it's an actual failure with the vent tubing in itself, in which when that happens, the easiest way to fix that is either you switch tubes, your vent circuit, excuse me, or the old golden glory of just turning off and turning it back on. The biggest problem also that we're going to see with that is sometimes those low O2 pressure alarms we're going to see is that we're just not meeting the proper peak, and that may have to be adjusted as far as increase so that we can actually have proper airway involvement. Obstructions of the tube. We're going to talk about, is it cant? Is the patient biting on it? Is there a mucus plug? Is there secretions? Is there something blocking the air getting to where you need to go for our patient? The easiest way we can fix that, suction, removing whatever obstructions that you have, or the aspect that the exhalation valve that is on the back end of our vent circuit is being covered by a blanket or by patient belongings or by our own equipment. Make sure that is always free to allow air to exhale out of there, because that also measures how well the patient's doing or how well the vent is doing as far as delivering tidal volume and the exhalation volume afterwards. Equipment malfunction and failure. Do we have a vent failure? In that case, remove it from the patient, add your BVM with your PEEP, and then bag with that until you get either your equipment failure fixed or until you reach your destination. Equipment failure is very frustrating in the aspect that if we have failure on that, it has to be taken out of service, reevaluated, and hopefully we can get it back in a timely manner. Sometimes it did crap out on it. Is the battery fully charged? We check it every day, should be at 100%, the last 10 hours without it being plugged in on its battery. So hopefully that never happens. Again, always reevaluate your initial settings. Look at what their settings are. Does it match your patient's, one, conditions, and two, how their physical presentation is. If you have somebody who is 6 foot, but with a tidal volume of 300, is that going to be appropriate for that individual? No, that is way too low of a tidal volume. We want to base it upon their ideal body weight and start moving that up. We're actually looking closer around 500, 520 if I remember correctly, with about where you want to start with that. So the paper that I hand out to everyone is, like I said, this is basic BiPAP rules. This is how your initial start should be when you pick up a patient who's on BiPAP. We are looking at the aspect of, okay, Bothwell's got them on BiPAP. What are their initial settings? What can I do to change to make it more comfortable or appropriate for our patient? So the way we're going to talk about this is that we talk about, are they hypoventilating or hyperventilating? We're going to talk about what's our O2 level, and then we're going to either increase our FiO2 or our PEEP. One of the biggest frustrating things about this is that you need to have access to their ABGs. People who are placed on BiPAP should get an ABG before they're placed on it, 1 hour after being placed on it, 4 hours afterwards, and then 12 hours. There's no real gold standard as far as saying, hey, try BiPAP for so many hours. If that doesn't work, switch to something else. The reality of the situation is it's all patient dependent. Ideally, most practice shows BiPAP's placed on, in 4 hours, are we seeing the changes that we want? If not, we need to adjust our settings. If they are getting to the point of respiratory failure or decompromising to the point where they can't tolerate it, as in losing consciousness or secretions in the airway, whether it's because they become nauseous from the high pressures of BiPAP, that they start to vomit and they have now a compromised airway, BiPAP's no longer appropriate for them, and you may have to move over to intubation. When you set up your BiPAPs, always have in mind what's going to be your next thing if this fails. What am I going to set up for if this doesn't work? We need to always think about, if we have a patient on BiPAP or CPAP, what am I going to need to do to successfully intubate this individual if this doesn't work? So the things that we're going to talk about as far as BiPAP, first thing to start off is we want to know if is our pressure support appropriate? So we look at their end tidal, or we look at their PaCO2 on their ABG. Is it going to be high? We're going to increase our pressure support by 2. Is it low? We'll decrease it by 2. Always to work in small increments when it comes to the vent, because small changes equals big results. Low O2, we are also looking at their PaO2 on their ABGs. If it's low and our FiO2 is below 60%, increase our FiO2 by either 5 or 10% until we hit 60. If it's low, but we are greater than or equal to 60, increase your EPAP. The big thing about that affects SpO2 for your patient, as far as oxygenation, is always going to be your PEEP or EPAP and FiO2. For your end tidal, it's always going to be volume and respiratory rate. So we look at that. Now, if we have a high O2, our FiO2 is higher than 60%, we can decrease it by 5 or 10 so we hit 60. Or if it's less than or equal to, decrease your EPAP by 2. That's where we're going to originally want to start with our settings on making our changes and see how improvement goes from there. Now, the frustrating thing for us is that we do not have access to in the field ABGs, but we do have our monitor, we have end tidal, we have patient presentation to help us determine if our settings that we're going with are moving in the right direction. Other frustrating thing that people need to realize is that when you make these changes, it's not going to be an instant change for the patient. It's going to take a couple breaths, maybe a couple of minutes before we see, is this working in the right direction? Give it about 5 minutes, 10 at most, to see if you need to start changing it. Especially if you have somebody that you're picking up who looks like they are air hungry, or there's someone who looks like they're struggling at Bothwell, but for some reason they're choosing not to intubate, but they want to give BiPAP a try. Give it a chance doing your changes to see if that works. If not, start preparing for your innovations. So
what's the initial difference in the numbers? Like when you turn it on, start on BiPAP, what's the initial gap between EPAP and EPAP?
So when we set up BiPAP like in the field, our initial IPAP or pressure support is going to be 10 or 15. Your EPAP is always going to be 5. So that pressure support chain difference is going to be 5 or 10.
And that's like the ideal gap right there.
That's right there, kind of where you want to be. And again, depending on how large of a difference between your pressure support and your PEEP or your IPAP and your EPAP, the greater volume the patient is going to experience when they initiate that breath.
Right.
So
if you need a higher tidal volume, your gap would ideally be 10 instead of.
yes, that's kind of what they do. Again, and what we also want to think about is what kind of respiratory failure does this individual have? Is it type 1 or type 2? Someone who's got CHF, they're going to need more positive and expiratory pressure to recuperate more of that alveoli, to open up that space, to push out that fluid, to allow the lungs to be fully involved in the respiratory effort, as compared to someone with COPD, where it's more of an air trapping, where we're talking about whether it's emphysema or bronchitis. So again, ARDS, CHF, pulmonary edema, a higher PEEP may be needed. And if you still want to make sure that you still have that 5 or 10 gradients or variance between it, you're going to have to increase your IPAP as well, just to make up for that. And we'll go over some scenarios as far as setting that up, going over those initial settings and seeing where you guys are at comfortably wise as far as figuring that out. Again, pressure support is just simply your IPAP minus your EPAP, and that's how we originally started. Again, in the field, like we said, talked about your initial BiPAP settings, either 10 over 5 or 15 over 5. FiO2, start at 60 and work your way up from there. You can start at 100 if you choose to. Just know that you will have to be backing off on the FiO2 at some point once you know the patient is comfortable and stable with what they've got going on. There are some things you can do as far as the individual that has really high variations between their IPAP and EPAP, like a really bad COPDer who, let's say we pick them up at Bothwell and their initial settings are like 20/12. That's pretty high inspiratory pressure, and as soon as you take them off of that, put them on ours, just trying to recuperate all that support they've had is going to be lost. You may have to start in CPAP mode and work your way up to a better IPAP. And you can do that with our vent very easily. Set it to CPAP. The pressure support's already set at 0, and with your EPAP already at 5. Just add your pressure support at 5. That way it's a constant pressure. Slowly increase that to where they were comfortable before, and then increase your PEEP after that. Again, always make sure that your FiO2 is adequate for your patient as well. Make sure we're always keeping oxygen saturations above 90% as best as we can, ideally anything greater than 94.
And if you say increase the EPAP by 2, we're increasing the PEEP on our ventilators,
Yeah,
correct?
that's correct, yeah. Like I said, anything that we do as far as our modes that we do, whether it's tidal volumes, do it by 50, small increments like that. If you're doing our peak inspiratory pressure, where we actually talk about the upper airway pressure, by 2. PEEP, same aspect of that. So we're going to do a scenario real quick. So what the idea is, what I want you guys to figure out is not only what our vent setting should be for this individual, but also if we choose to use a different mode, where you start at, and then if you have to go further to the point of doing the most invasive thing, which is doing an intubation, what drugs are you going to use, what's your calculation for them, and where do we want to be as far as like sedation goes if we need it afterwards. So you're responding to a 27-year-old female, respiratory distress on room air. She's 76%. She has a heart rate of 120, sinus tach on the monitor, respiratory rate's 38, blood pressure is 140/78. As far as what we see with your, what's our biggest concern for this lady? Yeah. Let's say she's had this been going on for a while. You originally see her, she's pale, she's diaphoretic, she's got accessory muscles that are being used, and she just looks very tired. What is that, with that presentation, what's the first thing that's going to come to your mind? She's on the verge of respiratory arrest, of just giving completely out because she has worked so hard to make this happen for so long, her body's getting ready to go. She's 5'9", she weighs 170 pounds, she has a rescue inhaler, she's diabetic, and she takes insulin. So, real quick, just based upon her height, what's her ideal body weight?
66.2 kg.
Yep. Okay. What's her actual weight in kilograms?
85, or 80 if you divide by 2.
77. So, ideal body weight, 66. Actual weight, 77. Why is that such an important number to think about when it comes to for a patient? It's because the medications we're going to be giving. Ideal tidal rank volume is going to be anywhere between somewhere around 400 right up to 530. Respiratory rate, 12 to 20. We want to determine based upon how well she's actually breathing. Are you going to use AC mode, or are you going to use SIMV for her upon your initial intubation if you choose to do it?
SIMV.
Okay. Why SIMV as compared to AC?
Because she's still kind of actively breathing. She has a respiratory rate right now.
Okay. Yeah, that's a good point. The thing is, though, is like if we introduce a paralytic now, are we still going to be using SIMV, or are we going to be using AC then? Okay. You can still use SIMV even with the paralytic. Just keep that in mind that when it wears off, the patient will start having a respiratory effort as long as they are not in full arrest, and that hopefully their diaphragm is still working so that they can have it. Are we going to be doing more of a pressure support with her, or like as far as are we doing a pressure control, or are we going to be doing more volume control with this one?
Pressure should be trying to open her up.
Yep, either one actually doesn't really matter. I would start, if for this individual, do AC mode pressure. It is the most, or excuse me, AC mode volume is the most common vent setting that you will see and initiated for intubated patients in the hospital and pre-hospital setting. So it's not a bad starting point for this individual. just know that if you're taking this patient on the vent, or you have a longer transport and you're not going to Buffalo, so you're going to Columbia or to Kansas City, maybe you're gonna have to make some changes as the paralytic wears off or as they become more comfortable with it to better support your patient. If we were gonna do SIMV volume, will we add pressure support for this individual? Pressure support is always going to be about 10 is where we're going to start. That's the idea of thinking of your patient's breathing through a straw. It, over time, becomes very difficult for anyone to breathe through it because of the amount of resistance that you need. Pressure support, added to that on there, helps them breathe in a little bit easier, makes it easier for the patient to actually initiate that breath so they're not going to tire out. We do SIMV volume, pressure support. Someone who's got a severe asthmatic, what do you want for your IDE ratio to be?
To be 1 to 4 or 1 to 5.
If it was pretty severe, yeah. A longer IDE ratio. Generally, most people start off at 1 to 2.5 or 1 to 3. 1 to 4 gives the time for the patient to offload that carbon dioxide before they initiate the next breath. This is going to allow the, like I said, that end tidal to start coming down as we really help that patient offload that CO2. Biggest problems that you may run into if you don't have a proper IDE ratio is that breath sucking can happen, or they feel like they are just not able to offload the volume that they get. So you're going to see issues as far as auto-P, breath stacking, where then we start moving to the aspect of barrel trauma, aspect of we're now injuring the lung that we're trying to protect. Make sure we are always using our end tidal waveform, gold standard for any intubation. Every patient on the vent should have end tidal attached to it. You can attach end tidal to CPAP and BiPAP. I've done it on myself, it works. Just know that the number you're going to get is going to be slightly lower than what the actual number is. Just keep that in mind when it comes to your BiPAP patients if you're using it as far as making the adjustments that you want to. So, if you were to intubate this individual, what's going to be your drugs of choice as far as your paralytic and your induction?
Now, before you intubate, I would go and try to do some breathing treatments,
Okay.
some ME and some MAG probably before I go down the old intubational. That'd just
This
be me
one,
personally.
yeah. But now, if, like I said, if you go back to her, she's pale, diaphragmatic, she's on the verge of respiratory failure. Are those drugs going to be able to work in time for you to actually see the turnaround that you want? Probably not. Secondly, MAG, which is great, problem with that, smooth muscle dilator, also causes respiratory depression and decreased LOC. So they may, while getting better, start becoming unresponsive. Things just to consider about those drugs. I would say even if you choose to intubate this individual, do your inline NEP treatments for this individual. Go ahead and do your MAG treatments with this individual because you have full control of that respiratory drive. You can start adding those medications on, you're going to see that improvement. Hopefully they're not on the vent for very long. One of the biggest problems with the vent for our patients is that the more that we use long-term paralytics on these individuals, the diaphragm is a muscle that loves to kind of give up when someone else is doing the work for it. We are a negative pressure ventilation just by nature, and once positive pressure ventilation is introduced, the diaphragm's like, I don't have to work anymore, someone else is taking over, deuces, I'm out. Over time, it doesn't want to initiate that drive once it's coming back in. So their time in the ICU, their time on the ventilator is going to be so much more longer. We're looking at maybe 3 more weeks in time in the ICU that they didn't need because of improper management of medications. Any other questions on this one? What size tube would you use for someone who's like 5'9" and feet?
7.
7 would work. That would be fine. Bigger thing is this. That tube size, you kind of want the largest one you can possibly get in for your patient because it's going to decrease that resistance and allow better airflow to go through and better compliance with our patient and our vent. And we won't be running into those issues as far as those problems with high pressure alarms or low or high airway resistance as well. Okay. The next 3 scenarios are all going to be purely on BiPAP. After we do that, we'll just take a real quick little break, and then I've got 2 vents. We'll split into groups of 10, and basically we're just going to go over each mode, the different alarms for each one, and how we set that up. We will also just go ahead and initiate BiPAP on me, just so you guys know how it's set up, what it should look like, and some problems that we'll run into for someone who has a spontaneous respiratory drive, and some of the alarms that we run into that make us second guess on what we're doing. So continue on. So again, our initial BiPAP settings are going to be IPAP 10, EPAP is 4, FiO2 is 0.45, so percentage-wise, what is that? 45%, yeah. ABGs, what we are looking at is our pH, our CO2, and our O2. pH is 7.28. Is that acidotic or alkalytic? Where are we at? Yes. What is the range for our pH?
7.35 to 7.45.
Yep. PaCO2, 75. Is that high or low? Okay. What is our normal, what's our normal PaCO2?
35, 45.
Yep. So what we see on our monitor when we do our end tile, we're actually, that number of 35 to 45 is actually based upon ABGs. True respiratory CO2 is going to be a little bit lower than that, but not by much that we can still account for 35 to 45. PaCO2. Is this low, or is this high, or is this in the right where it needs to be for this patient? This is low. PaO2 should be between 80 to 110 is where normally it should be. So, first thing we need to figure out is what is our current pressure support with this patient with these current vent settings, BiPAP settings. Pressure support, what is it? Yeah, because we're taking our IPAP, subtracting our EPAP, and that gives our pressure support, and that's 6.
So this is what, like, we go to Buffalo with the patient, we're gonna see, okay, IPAP for 10, EPAP for 4, so our pressure support on our vent's gonna be 6. And then PEEP would be 4.
Wait, so what we're gonna see with ours is, yeah. So what you will then actually seeing is that if you have an IPAP of 10, and our pressure support, we need to add that to it, so it would actually be, you will see 10 over 4 for them. Ask if they even have pressure support added with it. If they don't, then take that, and then what you get for your pressure support, add that to this. So your IPAP would be 16 over 4, so that you have the proper thing we need with pressure support. Again, current pressure support with that one is 6. We need to figure out what needs to be our new pressure support. What was that?
8.
How'd you get 8?
And 2.
Okay, why did you get 2?
Because of high CO2.
Yep. So if you look back at the little cheat sheet that you have on there, your high CO2, we want to try and decrease that. We want to increase our pressure support by 2. So our new pressure support should be 8. So with that being said, what should the IPAP be then?
What was it?
12.
Again?
12.
If you guys want to write it down real quick, just so you guys can, like, as far as reviewing it with yourself. So again, EPAP's 4, your IPAP is 10, FiO2 is 45 to 0.55. Okay. So then our new pressure support should be 8. The IPAP, to achieve that, because we're not increasing our P. I'm sorry, we are. We're going to do the 12 for our IPAP. EPAP should be 4, and our new FI2 between 0.5 and 0.55. That's where we should, as far as moving our ventilator or BiPAP settings, due to their current recent EVGs. Everyone confused?
Palmer, is there any way we can get a printed version of these slides?
Yeah, I will.
That would be awesome.
I will email it and print one off for those that want it. So,
Okay, why don't we just put it on the file center in Target Solutions? That way,
That would be
that way you
great.
won't
It'd be a large file on your email, so.
So that's what we have. With that going on, we trying as best as you can to come around to your closest vent. And again, for those that are not as comfortable doing the setup or where everything's located, please take this time to learn as you can. Learn now where there is no patient attached to it. There's nothing really compromising for this as compared to trying to learn it when you need it for your patient.
Yeah, it's all you.
So what you're saying is just wait and call you, okay, come on.
No.
Don't call me either.
No, I am going to look at my phone and be like, "Good phone do this."
Yeah. Oh, Regina, you got it.
She just looked, laughing and joking and everything with it.
So we're done? Just setting it up?
Yeah, that's what I wanted to do. Let's get the initial setup and then we'll go from there.
That's gonna have one.
So when we do our initial setup for the vent, what are the things that we are actually doing prior before we get them connected to the patient? We're making sure that it actually functions right, that we are able to meet high pressure alarms, any low pressure alarms that we notice, and that there are no leaks when we attach it to our test log. Make sure you always test your vent prior before putting them on that patient with that test log to make sure that your settings are appropriate or that there's no problems with the vent. Turn on. What's it say? No patient detected. So, you guys want to test your high pressure alarm?
It's working.
Cover it up on the end. So we're in easy mode.
Little boner.
To just seal off the ends. We should see high pressure alarm.
Just push that button and stop. As long as the patient's not blue.
Is all the new ones. You said there's quite a few.
It fall off.
He's got like 10.
Put it on there.
You're playing good then.
I'm colorblind. Here it comes.
Because they don't have freshman, right? It's just JT first.
We'll just blame it on the shitty case.
That's it, right? Freaking show up then.
It fit on the hole. That's all it
They're gonna cut like 10. I said, I can remember it there. I said, they're gonna try you over the spots. Don't just think the obvious. You're gonna go out there and catch your lap. It's not gonna be like
We would
that.
have figured it out.
So she said she did kind of screw up there.
Okay. So what mode do you guys have set now?
We got AC pressure support.
But I think we need breast per minute.
But you just forced it on there?
No need 23 breaths. Speed video temps. It's supposed to be on.
So what currently as of right now, when you turn on your vent, you choose adult, and pediatric, or CPAP. So we always start with our adult, so that's what generally what we're gonna be dealing with. So we do with our adult. And default setting should be AC volume, setting of 500 or 450 for our volume, respiratory rate about 14.
So we start volume.
So when you start.
It's not like it's damn good one.
It should be. If not, it will be the last mode. If you choose adult, set the 450.
Species specific.
Oh.
As you do.
You just fire that thing off.
High pressure.
That's what they charge. See if you're blowing some lungs up, John.
FO2 is currently set to 21. Just for right now, we're going to keep our FO2 at 21. That is room air, so we're not messing around with oxygen alarms.
Really broke on it.
But where would we initially start for FO2?
Like, you know,
40, or start at 100, work your way down to 40. Peak inspiratory pressure.
Jacket.
This is what we see here. Currently, right now, it is not highlighted.
So now you're
Why is this?
portraying fatty.
Can't adjust it.
Why can we not adjust it right now? That's right. So when you change volume, your peak inspiratory pressures are going to be variable. One thing that's nice that we can do with our vents is that we can measure plateau pressure with a peak plateau mode. Yep. What that does is it measures resting alveoli pressure without any airway movement. This is the pressure that's holding open the alveoli. Why is that such an important aspect? Is because we're going to try and figure out, do we have proper lung compliance when we are doing that? They can only be done with a volume control, not pressure. And the reason why is pressure is always constant when we're in that mode. So no matter what, our P-plat is going to be at what we set our PIPs.
I got a question.
Yeah,
How do you get over these to change your trigger?
I will show you. So volume right now, because it's highlighted, we can control that. So Bobby, go ahead and change our 450 to 500, and let's see what happens with our PIP. Okay. So right now, 25. Again, small changes, big results. Our PIP should never be higher than 30. Absolute highest would be 40, but we're always going to try and stay below 30. The reason why is if we know our PIP is below 30, our P-plat or peak plateau pressure is never going to be higher than that. We want our gradients of somewhere between 15 to 20 for that for most of our patients. Breaths per minute, not too bad. I to E ratio is 1 to 2.
I changed that.
Okay, go ahead and change it to 1 to 2.5 and see what happens.
What happened?
This one goes up to 6.2 on this one. And that's 660.
See, it's giving me a lot for that, so some people just go straight to that.
Yeah, instead of looking at the 850.
Yeah. So we are actually doing high pressure alarms. Your alarms are set here off on the side. You can control this by pressing your menu button and highlighting it. My suggestion for you is when you set your high alarms, set it to be like your for your tips, your pressures, 5 above what your target rate is, and then about 5 below what the lowest one you want it to be. So most of the time, 10 or 15 is good for that, and a PIP of 30 is okay as an initial alarm. So, yep, go ahead and change it to 30.
So AC and PFR.
But 30 is high as you hear it, right?
30 is about as high as where we want to go. But that's, I mean, like I said, we were having PIPs of 20, 25. That's good. 20 is like perfect if you can get there. Anywhere between 12 and 20 is great, but 25 is okay. Again, as long as it's lower than 30, we're fine. So with that, we have we can change any alarms that we see here. We're not going to worry about heart rate standby or SpO2 because again, we use our monitor. FiO2. We can set an alarm for that if we want to. There's really no need because we were constantly monitoring it anyways. We already have our high alarm set for 30 and our low set for 10. Currently right now, in our mode of this, we do not have any kind of volume limits because we have direct control over that. If we were in like pressure mode and we were controlling PIP specific, we can set alarms for our tidal volumes. To get over here to say you want to change your trigger pressure, hold. Sorry.
What's that random mark button do?
We might be able to do it with volume. There it is. So you're going to pressure, trigger level, -2. What this is a response to is the actual aspect of the patient's ability to trigger a breath with the ventilator. When it's less than -2, we're seeing an increase, meaning that they need to, it's a lot harder for the vent to actually trigger because they have to take a deeper breath because we're thinking negative numbers, thinking negative pressure. So that,
So
You're
say
gonna-
like that patient we had, he's on BiPAP,
yeah.
shallow breathing.
Uh-huh.
So which way you're gonna?
You're gonna go up. You want well, actually, you're thinking about is a rise time of 3, and when you're on BiPAP, rise time should already be set to 3. So when we talk about that, we'll go over into that aspect just because currently right now you're not gonna be able to do rise time with mode. But trigger modes is how well is this vent going to correlate with my patient as far as triggering a breath for them. If we are going in the positive direction, so like -1, 0, 1, or 2. This patient could just hiccup and it will just go nuts because it's gonna fingering, it wants to take a breath. Generally, let's start at -2. If you need less, go to -1. If you need more, just go up to like -3. You don't really have to go anything higher than -2, but -1 if you're someone who really just does not have the drive to initiate the vent like it needs to. So if you will go ahead and switch to SIMV real quick. Go to volume. Okay. So what we have here now,
Should we use who's coming from
whatever the patient's currently on, if they are able to comply with that setting and everything looks great, stick with it. If something doesn't look right, assess your patient. If they have respiratory drive and they've got good sedation, but they've still got respiratory drive, SIV is fine. But if you need to increase sedation or for some reason you have an ARDS patient where you've done all you can and you just cannot get them to comply with the vent, do a long-term paralytic, switch to that AC mode, and then worry more about those pressures. Where's our starting point? What's our IPAP going to be at? 10 or 15 over what? 5. Okay. FI2, where do we start at?
40.
IPAP, we're going to start somewhere around 60. We're going to start 60. We're going to go up maybe up to 100%, work your way down if needed. 40 would be the absolute lowest that you would go for either the vent or BiPAP. So for the sake of making sure that we set this up right, I'll have you guys collectively together put BiPAP on me. Some things that we are going to go over. I brought the monitor over so we can attach end title so you guys can see that you can monitor that with BiPAP for that patient. Big things is that what I talked about in the slides that we haven't talked about yet is leak compliance. For BiPAP or CPAP, we have the ability with the vents to do leak compliance in the fact that the vent will recognize there's a mask leak and compensate so it's just not constantly throwing volume at somebody thinking, oh, they're still trying to take a breath in. Individuals who have full facial hairs like myself, I personally have not shaved just to prove a point that when you have a mask on with someone with facial hair, you need to attach or apply the leak compliance mode on there so that the vent's not constantly going nuts. With that being said, the numbers you will see are not true numbers of what the patient's experiencing. You are going to have incredibly high minute volume and tidal volumes like into the thousands for your tidal volume and minute volumes like up to 30. Biggest point with that is that that's kind of frustrating as far as what we need to write down for our patient when we talk about putting them on this vent. The reality is when you set them up with the leak compliance, we're trying to make sure that they're comfortable first and that they look like they're able to breathe adequately before we start moving towards, okay, now how do I set my parameters to make sure that I'm actually reaching what I need to reach. So, well, guys have, I'll have you guys work right up here. We'll attach this. Okay, again, we are going to go to SIMV. Sorry. We're going to go and set up BiPAP. Someone bring the monitor up here, Keith. And I think there is a,
You want the thin line?
Yes, I do.
It gets over your 5 count limit.
That's on this one.
Busted.
Yes.
We're only doing small groups.
He's small.
Like that. Mask fits just like it would for the endotrachea too.
He's nice anyway.
Raise up and I like to set up, when I have on inside, I like to set up my SpO2 and my waveform. Okay. So if you're going to set up BiPAP, go ahead and put in your initial settings. You guys do it.
Get it green. You nervous? The heart rate's 110.
Palmer, I think we need a pressure.
No.
How about a pressure and a full 12?
No. No, last time I did that, my pressure was like 160 over like 110, and heart rate was like 124.
If it's a breathing problem, that's our protocols.
Yeah.
We have to.
Oh, I know.
Sorry.
So what do we currently have that's set?
10 on the flat.
Okay, and then currently right now we do not have the leak cuff added, so that's fine. I don't add it. I want to. So okay. Then when it comes with the mask, you want a good proper seal.
You should get a photo of
Okay. On Facebook.
This makes it more
Okay, what do you currently see on the wall?
What?
Sean, do you say he's your
Title volume is 712. You're breathing so fast.
He's nervous.
Okay. I know you guys can't hear me that well, but right now we do not have leak seal on. So we're getting a number of alarms that are not true to what's going on for our patient. In additional, we have a tidal volume of 700. Do I look like someone who's taking in a tidal volume of 700? No. The rate, we've got about at 18. Not too bad. For the look over here, we have an end tidal of 40 and an SpO2 of 99%. Are those decent numbers? Yeah. Worry about what you see over here before we start messing too much with what's going on over here. If they have decent leak, like which I do have. So when you attach a leaked compliance to it, it's going to remove alarms for your volume and your rate. And it's going to start going, things are going to skyrocket. It's like, we know we have a leak, so we just need to make sure that the vet knows that it's just going to be delivering volume as needed. But those volumes and minute volume that we see are not true to what the patient is actually experiencing. So to attach it, we go to our mode, click until we see our LC, switch it. We will get a leak compliance notification, acknowledge it, we are going to see channel volumes right now within 1,000. As it's compensate for the leak that it has. That is totally fine. Allow the patient to know that this will happen, and that we're trying to get it as calm as we can.
Smell the
And
rose.
benzos are going to be your friend in this case. Just make sure that you do not over-sedate them so that they cannot actually breathe. And it doesn't help if all they're doing is talking through all of this, because all it's going to do is this. Here's the scene. What is our SPO2?
60?
27. Just because the amount of pressure being pushed through. And forward to 10. What lines should we see? Intuition point. One of the great things about CPAP, BiPAP, if they're not comfortable enough to take this mask, try to calm them down, let them know that it does take a little while for it to start working, and that's compliance will make it easier for you. If you choose to use some sort of benzo for sedation, I suggest Ativan in smaller amounts. You can always give more, you can never take away, especially when it comes to sedation medication. So if you wanted to look at this, and we wanted to increase our iPad to 15, go ahead and do that, and let's see what kind of changes we see on our average. Pressure, especially upon inhalation, compared to when it was before and working against it. Sometimes it's a little uncomfortable. But we see with our oxygenation, it's still at 99%, and our end tidal is 34, still within the range of where we need to be. True thing about this is that, again, look at your patient and assess them on how they're doing. Use your monitor as a tool to help make those assessments. We're always told to treat the patient, not the monitor. It's correct. Treat the patient, but assess with your monitor. Any questions?
Any unnecessary questions?
Yeah. Okay, you guys good? Okay.
We're gonna take it off, but we actually gotta take care of it.
No, that's not comfortable shit.
I need to repeat all this with you.
Some of the biggest things, like I said, when it comes to that leak compliance is that you will see high volumes, high minute rate volumes that are just not correlating with your patient. Be aware of that. Just know that those are going to be not the true values until you have a patient who is stabilized and comfortable on that BiPAP before you want to switch that off to see where they're actually at. Yep.
Are we still putting a filter on these in line?
Yeah.
Now that we're going back to,
They should have a filter on your patients when it comes
so
to.
that's gonna throw it off a little bit also.
There will be some variations, especially when it comes to your end tidal. The volumes delivered, whether it's by volume or pressure, that it won't be terribly too much, but more so depending on where it's at, your end tidals are going to be slightly different from what you're actually doing. Just know you may get some sort of issue as far as dead space would probably be increased as well because of that filter, but not by much. So it shouldn't be terribly too much of a difference with how you set up your patient on your vent with that filter added on. Any other questions? Yeah.
So since you have the leak compliance, you would have to mess with like maybe even trying to, with the small amount of facial hair, like that you have putting lube around the mask to create a seal?
You can try like with Vaseline.
Yeah.
That would work, but the problem is that it's still like even when you create that tight seal. I mean, the biggest thing about is like really cranking that mask onto them to get that seal. If they are still not compliant with it, I mean, you might have to shave them. It's kind of a ridiculous to do, just shave just the area where the iPad mask is going to be, but.
Some of those guys are faced just filling
Yeah,
after that mask.
it's gonna, but is it really, you gotta crank that thing down on them to create as best seal as you can. But other than that, I mean, that's the best you can do. Like I said, the full facial masks are a lot more comfortable compared to your traditional CPAP one. Just for S&G's last night, I went through that one on me for about an hour just as I was messing around with it, seeing what crazy things I can make it do. And I can tell you that's a lot more comfortable for your patient. It gives them a fuller view of what's going on so they don't feel as claustrophobic as something that's on their face like this, as it feels more like a scuba dive mask and the fact that you have a full view of what's going on. So that's ideally something I would use for my patients compared to the CPAP mask. Any other questions? Okay. Well, I mean, that's all I've got for you guys. I appreciate your time. Like I said, Justin will have some out for the evaluations and the target solution stuff. Other than that, unless anyone